Thank you very much. I want to thank IFSES for the invitation. Also, I want to thank SAGES for giving us the opportunity to share what I consider now a difficult task in this presentation. For this presentation, I don't have any other disclosures. The general ones are in the brochure. So I will show you some of the facts that I found. I did an extensive review of what is being published. That is not much, but I tried to put together some curriculum compared with fellowship, residency, and what we think about new technologies. And if we go back to the basics, you will find out that the Residency Review Committee, through the Accreditation Council for Graduate Education in the US, with the American Board of Surgery in 2007, where they have a big meeting in January, they decided something that it was very interesting for me. After they review what's going on with their programs in the US, they decided to increase emphasis in basic training, not in advanced training, not in laparoscopy, nor in any other training, but basic training, because they found out that the residents, when they were finishing in the US, they were lacking the basic that they need to go out to the real world and do general surgery. So that's a very important fact for me. And why? Because now they have a lot of obstacles. Dr. Eubank just mentioned that we went for any hours to 120 hours. Now we're talking 80 hours a week. So less hour work week for our residents. So they need to do training and learn outside now of the hospital and the ORs. There is a rising trend also towards subspecialization. There are some groups in some part of the world that they are proposing that after the second or the third years of residency, you already start to learn about the subspecialization you're going to pick. So why you need to learn about doing liver surgery if you're going to be a vascular surgery maybe? So that is a tendency for some subspecialties to ask you why we need all these 5 years if we're going to do something different. There is also an ever-growing array of surgical technology. Every day we get something new that we don't understand how to use, and sometimes we don't even understand what they bring us, this new technology that is worthless. There is also faculty time constraints. Now we don't have the faculty all the time with the residents. There's a lot of increase in operating room cost. Also, Dr. Eubank showed you now how we learn the step-by-step, and we are not allow our residents to do all the case. It's not only to learn step-by-step, it's also because if a resident do all the case by himself the first time, it will be 7 hours, 8 hours. Who's going to pay for that? Somebody has to pay for that. So if he does some, the operation time in total will be very close to the one we use. And of course, somebody's going to get sued when the residents, the fellows, and even the attendings are doing the cases. Liz Armstrong in this meeting, and I decided by myself to put these new slides because he presented in this meeting during the presidential debates these numbers that amaze me also. Only 28% of general surgery cases are done laparoscopically in the US. So now we're talking single port, robotics, to a group of residents that only they do 1/3 of their cases by laparoscopy. Also, residents and fellows are not doing enough cases during their training, and 75% of the residents who graduate, they felt they're not were ready to perform MIS. And so they're not ready for basic laparoscopy, advanced laparoscopy, so what do they want for do? So then move for the fellowship. In the fellowship core curriculum, I went through all what the fellowship council want from the fellows, and I found these statements. Understanding new technologies and their role in the care of their patients. So it's our missions to the fellows that they know what's going on. Even if we agree or not that is going to work or not, we need to discuss with them why it's not worth it, why maybe it's worth it, and to keep an eye on things to come. They also said that the fellows will seek feedback from faculty and develop a plan for filling gaps in knowledge of skills. So we need to know what they're lacking. But the question is, even if we know what they're lacking, are we able to provide what they're lacking? Because if they're lacking it, it's because we didn't give it to them in our fellowships. Because we don't have it maybe, because we are not trained to do it. So we're lacking a lot of things in the fellowship. Also, they bring me a new equipment, there's new technology coming every day. do we need to ask ourselves that for a technical advance to be accepted, it needs to be user-friendly, that most of the things you've seen, they are not that user-friendly. If we need to go to courses, didactic sessions, they are not that user-friendly. They're supposed to be relatively easy to learn, but they also have to be cost-effective. So what are the obstacles now when we talk about node, single-port, robotics? Is how many surgical departments really are regular practicing nodes, single-port, and robotic surgery? Very few. Every hospital is buying a robot. Most of half of them are in a closet in the hospital, or they belong to the urology department or the gynecology department. Also, do we have the available equipment? Who's going to pay for that? Do we have the patients for that? And they are going to give us the OR to practice with a robot for 9 hours in a patient when they need the OR to do the daily basis surgery in our cases. All of this is going to bring deficiency in laparoscopic training for residents. So if you use some tools like this, that they look very good for us, they're going to work very well, do you think you need to be trained for this? Yes. But before get trained for this, do I need to know how to use the basic one? Of course. Do I need to understand why, on when, on how I'm going to use that one? Of course. That was a beautiful view. But before you even think in using that, there are so many steps to complete, and we need to focus a little bit more on that one. For a very nice publication in the Bullet of the American College in 2008, from this group of young people, they did a very interesting study, and they came up with one of these conclusions. One can argue that the operation room is the worst place to first acquire new technical skills. If you don't agree with that I will agree with that. You just saw Dr. Eubanks showing how much you need to know before you go to the OR. He spent hours tying his furniture. We did the same. So if in your hospital, if your rooms where the residents stay, there's not a lot of knots, your residents are not trained themselves. They go in partying. So you go and check the rooms and you will see if they're really practicing. Also, we need training skills. There are two things that we know, the FLS in SAGES, and this is a big step. Now it's mandatory during US residency. That's a big step, because at least you know that the residents need to fulfill that one. Dr. Schuslep also present that now the lab is mandatory for the residents in Mexico. Latin America has the problem that every country have their own regulations, so by the time they approve it in every country, it will be a while. But it seems it's going to be also mandatory for the residents in Spain. So we are doing something to make sure that at least they get the basic training skills. There's no difference between this and my first bariatric case as a resident or a fellowship. Some of these planes will land, some they will crash. So we are going to kill some patients. So we need to kill as few patients as possible. So we need to do a better training. Then we came simulation in place. And there are two very important things that they've been doing in America. The first one is the college, through the AAPDs that was mentioned before, through their national simulation committee, they added simulation in the curriculum. It's mandatory now. Now we need to evaluate better how it works, but it's mandatory now. Also, in that paper that I mentioned before, all the studies have established that surgical skills are much better when you use a simulator. They showed that during the first year, the PGA1s had the skills of the PG3s and 4s if they used the simulation, as you can see it in these publications. Finally, robotic surgery. I'm going quick on this one, because I think robotic surgery at the end, it will be better than some of the other, and I will try to explain why. This is what's happening, how the procedure by robotic is been increasing in the United States in blue, international in green. Now there are more 4,000 robots all over the world that people are using. This is the base they've been installing international and in the US. This is the number of procedures that now you can do in general surgery with robotics. They are increasing also, but there are a lot of issues there, but there are a lot of help there. Very good immersion, very good environment. You are away from the patient side. The robot will try to stop you to do a lot of the damage in the patients, but there is a learning curve. There is a learning curve for the robot itself. So it's not that we can do whatever we want with them. There is a training proposal from residents with the arm setup, with the trocar placement, with the assistant, but also there is a training proposal for robotic for fellows with dry labs, lab colleagues, and post-fellowship further training. In conclusion, Mr. Chairman, training in further technical advances require a strong knowledge of laparoscopic surgical technique, deficient residents, training in advanced laparoscopy surgery, lack of trained trainers. So how are we going to train the residents if the trainers are not trained? Nodes and single port have not been standardized or show actual benefits today, but we need to make our fellows and residents aware of that. Robot as a simulator probably is the best role that I see now for the robot, but also robot is a very good way to decrease learning curve. But is it cost effective? It will be available for everybody. And I want to finish with this video.
Ciao Carlo, ti ricordi di me?
Maybe the IFSES board is going to expel me after this video, but it's fine with me.
E volevo invitarti a cena. Vieni? Ti aspetto.
Guarda che luna.
So that's my last message. Not everything you see is how it looks, and we need to look deeply in what's going on with our training and do a better work for our residents. Thank you very much.